for our friends and colleagues who cannot join us today live, so we want to be sure that they can watch it. So we record it, but just wanted to let you know in advance. So just a quick look at what we'll be doing. We'll be talking about, well, first we'll do a quick roll call to introduce yourselves and let folks know who's all on the call today. And then we'll talk about the current QI progress, talk about baseline, if you're having any troubles, questions, concerns, we'll talk about that. Dr. Anzolk will present about baseline data and how you can use that in preparing for your PDSA cycles and improvements in your office. And then we'll really dive into growth charts and goal setting and how you can incorporate that into your quality improvement work. So a good discussion by Dr. Sternstein at the latter part of the presentation today. So first, I can see who's on, so I will say your name, and at that point, if you could just remind us where you're practicing from and say hello to the group, that would be great. So we have Dr. Milton with us.
Hi, it's Alana Milton from Nationwide Children's Hospital.
Okay. We have Dr. Bardwaj.
Yeah, hi, this is Anita Bardwaj from Pediatric Center in the Greater Cleveland area of Broadview Heights.
Great, thank you. Dr. Singer-Clark?
Yes, this is Dr. Singer-Clark, and I'm with the Frontier Pediatrics Institute.
Great, thank you. Dr. Albrecht?
This is Alana Albrecht. I'm with Westfield Pediatrics here in Columbus.
We have Dr. Parks and South Dayton Pediatrics. Okay, so I know they're running in between meetings. So Dr. Riley? Okay, she might be muted. Dr. Valvul Rodiger? Oh, there you are.
Yep, so Prime Care Pediatrics in Zanesville.
Thanks. Do we have Kinship Foster Care with us?
Yes, hi. This is Lori Valvul-Rediger from Dayton Children's Foster and Kinship Care Program.
Dr. Yaw?
This is Dr. Michelle Yaw from Westerville Pediatric Specialists.
Sarah, would you like to introduce yourself?
Sure. Hi, this is Sarah Haig. I work at the Ohio Department of Health in Early Childhood Health, and I oversee the contract that we have with the AAP to implement the PMP program.
Dr. Olenschlager?
Yes, this is Dr. Olenschlager from Wadsworth Pediatrics.
Dr. Sternstein?
Hi, this is Amy Sternstein. I'm from Nationwide Children's Hospital here in Columbus.
And I know some folks, we have quite a few practices that have multiple physicians. So if you are watching together, please do let me know because I just see the one name. And so if you can just shoot me an email or say it in the chat here. So to the left bottom portion of the web page, you can see a chat. You can send messages directly to me. You can raise your hand, ask a question virtually, or you're also welcome to speak up. But that's just to let us know who's attending to kind of keep track. So I will just do a quick touch base. This is the stuff we've been doing for Module 1 here. So as we get into the pre-work and baseline data, we did our introductory webinar. A lot of folks have finished the Laying the Foundation webinar. The pre-work survey is where you'll engage in telling us some more about your practice, but also where kind of you sit in your work with nutrition and physical activity. And then those 2 baseline chart reviews. So we ask that you do this by this Friday. If you need some extra time, by all means take it. Because Module 2 is a little bit lighter on the data entry, there are no data entry cycles for Module 2, but there are a couple webinars. So you're doing the Hot Topic webinar today, so you can check that off your list. And then if you participated in the MOC2 presentation at annual meeting this year, you do not have to do that webinar either. So that should be updated on your My PMP progress if you did participate in that. If you didn't, I'll double check, but please also feel free to tell me. And then there is that one final Fresh Perspective webinar. So we ask that you have that by December 14th, and then we'll be in the full swing of things with Module 3. So the as I mentioned, if you need to take some more time to get your baseline data cycles in, please do. You're welcome to do that through Module 2 because there are no data requirements for Module 2.
So we are very excited to pass it over to Dr. Anzolk, where she'll talk about baseline data and our PMP progress. Sam?
Hi, good afternoon, everyone. Can you guys hear me okay?
Yes.
Yes.
Okay, perfect. So as Renee mentioned, I'm going to be talking about the baseline data that we have in to date. I pulled this on Monday, so if you had entered since then, this will be updated and you'll be able to see it in aggregate, and then you'll also have the ability to see your own individual or practice level data. So just real quickly, I'm going to be helping us look through the lens of the model for improvement to revisit PMP's aims as we review our baseline data and to start to think about how we can close any gaps that we see between where we currently are and the goals of the collaborative to boost our performance levels, and then kind of get us started thinking about what are some potential areas and opportunities for change. So kind of going back to our theoretical framework with this quality improvement work, we've looked at the first question of this model with what we're trying to accomplish and have our aim, as well as our measures, which are the second question of how we'll know that the changes that you're going to be making are resulting in improvement. So looking with our aims and measures in mind, the key driver diagram, focusing really on this left-hand side with the SMART aim of the aims that we have set out to accomplish with our process and documentation of obesity-related health risk assessments, our anticipatory guidance, and then how we are documenting items around setting goals and use of motivational interviewing. And then once we kind of orientate to where we currently are as a collaborative, and then if you have a chance to look at your individual data to figure out what interventions we may use from the key driver diagram to close those gaps that exist. So what I have pulled up and have taken screenshots of are the all measures report that's available for you to pull on an individual basis. I'll quickly highlight that after I go through how we're doing collectively. And then I also have screenshots of the chart review tool that you've seen if you've entered your data already to highlight what components are pulled to get to the data that we have presented on the screen. I didn't do it for all of the measures. I kind of focused on the ones that are pertinent to what Dr. Sternstein will be talking about, but I'm happy at a later time, or if you have other questions, to go through the chart review tool and how that corresponds to what you see on the screen for a specific measure collectively or for your individual data. So starting from the top and working down through our specific aims, we have some of our risk assessment measures. The first of which is weight status, and as you can see, we're right around 45% of the time in our baseline cycles of 1 and 2 of documenting the 4 components that we need to have for a child's weight status. And to remind you what those are again, that's having the child's weight, their length or height, dependent on their age, the weight for length or BMI percentile, and having explicit verbiage of the child's weight status, underweight, healthy weight, overweight, or obese. I mean, you need to have all 4 of those to kind of get that check that, yes, you had this documented. I did want to call out a note here with number 7, that weight for length or BMI percentile, and the box that's below. We only were able to have 1 label, and we didn't want to have multiple boxes. So don't necessarily think that BMI percentile, if you're reviewing the chart of, say, a 7 or 8 month old, you have to put the child's BMI percentile. You could look at what their weight for length ratio is. You can pull the BMI percentile for those over the age of 2. We just had 1 label for 1 box. So it's kind of for that child's age, put the respective numerical value in there. And then growth trajectory, which is really pertinent to what you will be having a conversation and what Dr. Sternstein will be talking about in relation to our growth curves. We have a little variation, but when you average it, we're right about 50% of the time of having appropriate documentation of growth trajectory. And that includes having updates to the growth curve, discussing and having documentation of that discussion of the child's growth curve with the parents, and also having a notation of what sort of change occurred in that child's percentile, be it an increase, maintenance, or decrease since their last visit, if they had a visit prior to this. And then the final two measures that we have are that are part of our risk assessment are a blood pressure for the age of 3 and above, and then for family history and obesity-centric review of history. The family history, again, is multifaceted, so making sure that we're reviewing and updating as necessary, and having that obesity-centric review, I think, is what's kind of pulling this measure down and is an opportunity for improvement. We then move into the anticipatory guidance, specific aim 2, that we're providing appropriate age and developmentally specific guidance around diet and activity. This is multifaceted, and what I have, the screenshot below the run chart, corresponds to the activity and daily structure, but the 3 main pieces that count towards this are very similar, be it for nutrition or the physical activity. So that we're, 1, looking at the current habits of that child, be it activity or diet. 2, that we're having a discussion, be it on age-specific ones, if there's nothing that kind of is of note that you want to discuss as an opportunity for change. And then 3, that we're providing a handout, a PMP-specific handout. And that's the main feature that's likely pulling this measure down, because the majority of you have not participated in PMP. You may have, since this is our 6th iteration, and you might have some PMP materials, but having documentation of that PMP handout is one thing that counts towards this measure. And as you get that built into your office flow, that will help bolster this measure. And then this final set of slides looks collectively at specific aim 3, our use of motivational interviewing and our goal setting. So are we using motivational interviewing strategies? You don't have to have explicit documentation of what those were, but are we doing that with patients when appropriate? And then looking at for families that had some sort of quote-unquote red flag, any of those red boxes on your chart review tool, that we're setting a goal if they have accepted to set a goal with you. And then the final one is that goal follow-up, that we are looking back at our previous chart, and if a goal had been set, that we're following up on that. This is one in the past that has traditionally been, all 3 of these have traditionally been a little lower performing. They're a little harder to get clinical processes embedded and strategizing. So that's one of the reasons we wanted to have this conversation today, to figure out how we can surpass the lessons that we've learned in the past and kind of put a good foot forward earlier on so that we can ingrain these habits as we move forward. So just looking at motivational interviewing, we're about 10% of the time that we're using some sort of strategy when appropriate. Setting goals with the family, and these are, it's even a smaller sample size here, I forgot to mention that. So the subset of patients is not the same as what we looked at before. If you noticed on the earlier charts, there are about 60 to 70 charts included. For motivational interviewing, we have about 20, and then that drops even further for goal setting, where there are only 8 and 4 applicable families, and the goal follow-up was 4 and 0. So we will likely see a little more variation with these measures, because not all of our patients will be included in this, but just to kind of call that out. So when you're interpreting your own data, 1, you may not see anything because you didn't have any pertinent patients, and 2, this, given smaller sample size, will be a little more prone to variation until we get some processes embedded. With that said, goal setting has hovered around 12 to 13% of the time that we're setting goals with families when appropriate, and we're not doing anything currently in terms of our goal follow-up when that was noted at a previous visit. I think there are a lot of opportunities for us to work on this area and having those conversations with families, and hopefully some of the items that Dr. Sternstein points out around our growth trajectories, and that can kind of help you on the right foot with that. What I want to do is just quick pause here if anyone had any questions about the data before I move on to a little more about measurement and the KETA data system. Okay. So the second question of our model for improvement was looking at how we can note whether the changes that we're making are resulting in improvement and the measures that we've put into place. So we know where we stand with respect to the collaborative aim and our measures goals, and we can start using measurement to monitor what direction and the effect of our improvement efforts are having on our collective data and in your individual data. And this is not just for this improvement period as we're working together, but also as you wrap up the quality improvement project to kind of keep that momentum going and take you in the right direction so that you're not only reaching the aim now, but you're holding those gains and maintaining them for the long term. So particularly at the beginning of improvement work for PMP, our main objective is to learn from what we're currently doing and to help us characterize our gaps in the care that exists so we can work to identify what some first steps may be to help us improve of the risk assessment, our anticipatory guidance, and the weight management techniques documentation that we're working on. And then we can look through the lens of analysis and how we can work with the data, not only know how the different efforts that you're taking and trying are impacting your documentation efforts, but also to kind of look at some of those qualitative experiences too. So we have nice, hard set measurement in our run charts, but the information that you experience, the PDSAs that you may do more on a qualitative level or your interactions with your patients, those also help inform your efforts anecdotally and can impact the steps that you take forward. So kind of thinking about those two ways of measuring things, not just the hard data that we have in our run charts, but those experiences that you have as well. And then using that look and have the feature within KEDA with measurement is real-time data to drive your improvement. So as soon as you enter and close out a cycle within KEDA, you are able to look to see what impact the changes that you're thinking about or you're going to be working on have had. So that you can analyze that data, determine whether or not that was an appropriate change and how that impacted your data, and determine your next steps forward. So it's really just kind of playing upon that model for improvement that we have where we know what our aim is, we look at our measures, we look at data, analyze what has happened, and kind of take that cyclical movement throughout this project with each change that you make to determine what your next steps are going to be. To look at your data, and this has been in one webinar and will be in a future webinar, I just wanted to quickly call out, I won't spend too much time on it, given that it's touched upon in multiple places, but to get at your own individual data, the same place that you've entered your data, where you set enter button, you will also see an analyze data button once you've completed the 6 charts per cycle. And you can either click on that analyze data button or through that drop-down menu, there is an all measures PDF. If you simply just go to select a report, scroll down and select all measures PDF, you will get very similar run charts to what I just presented earlier on that are specific to you, and as we group you, if you are participating with other providers from your practice, specific to your practice. So you have that option to select your data and your practice data and see how everything's working. And this helps you inform and use that measurement strategy to figure out what are good opportunities of change for you. So you'll have that data in a nice PDF, all the run charts specific to the data that you've collected, and it's also available through that Analyze Data button. We went over this on the pre-work phone call. So you just click that Analyze Data button, you get specific numbers, not necessarily a run chart right away, and then you can pull up those individual run charts as you scroll a little further down, and that's displayed here. So just some ways for you to gather and see your specific data so that when you are ready, you can work on the third component of the model for improvement. What change can you make that will result in improvement? And then help you think about what those opportunities for change may be and to put them into the PDSA cycle. And that's really your method for carrying out change. The details for the PDSA cycle and office flow are in not the next module, but the third one, and may also be covered by Renee if she comes out to you personally. But that will give you the strategies for going through and thinking through a PDSA cycle once you've determined what an opportunity for change may be. And some things that may be helpful for you as you approach your data and have digested it and may have thought about it and discussed it with your team is to kind of strategize. So there may be an opportunity to create an evaluation plan. And this isn't something that's really detailed, but it's looking at your data, aligning with where you are and where you'd like to be, especially if you've set a different type of aim outside of what we have for our collaborative. And just think and map out, what is a very easy change that I can make now? What is a medium-term change that I can make? And what's an ultimate long-term change that I would like to happen? And think about the stepping stones that will help you get there. You can certainly use the interventions from the key driver diagram, that right-hand side. They have evidence from the literature. They have best practices that we've learned from previous participants to help you figure out how can I get risk assessment in there? I'm doing really poorly in this area. What are stepwise, bite-sized pieces that I can take to get comprehensive risk assessment in place? You can start with the weight status, and it may be something simple as just putting that verbiage in your chart about the child is of healthy weight, a very simple and low-hanging fruit that you can work on, and then kind of work to build the rest of the components around risk assessment. So that's one place that you can start looking for ideas within the key driver diagram. The next is the office flow, and again, that's a module, a webinar in a future module, but that helps you look at what processes you currently have in place and how you can fit some of the kind of functional tasks into your office flow that help you meet the documentation criteria that we're looking for. For instance, providing those PMP diet and activity forms, where does that really fit within what you currently do, how you normally collect history from families, and how can you layer that in? Providing the PMP age-specific handouts. So we have that binder or spiral of handouts that you've received, and that's one of the components that's needed to meet the nutrition and physical activity anticipatory guidance measures. Where can you put those handouts so that, one, you remember to give them, and two, you have a place in your medical record to document that you provided those. So by going through the exercise of office flow, you can take what you're already doing, build upon the systems for what you do for other components of your well child care, and layer in those PMP-specific items. And then just figure if it's beneficial for you to kind of do low-hanging fruit and build your confidence and kind of get your momentum going, or if you want to go for something a little higher and incrementally work towards that over the course of the collaborative. Just some food for thought and different strategies that you can take as you interpret your data and determine what your next steps are going to be. With that, before it goes over to Dr. Sternstein, any questions about what I've just presented on?
Have any questions either about entering your data, any challenges you've encountered that haven't been resolved?
I think the only obstacle that I had entering in for information is one patient we did not get a BP in it, and it made us still put in the answers of the blood pressure. So we just put in 0, 0 since we did not collect it. And we said no, but it was still a criteria that we had to enter in what the numbers were. Yeah, and we still had to check abnormal, normal, and that kind of stuff. So we I don't know what we clicked on that one, but it wouldn't let us continue with the asterisks next to it.
Okay. I'll talk to the developer about that hard stop that's in there. So if you've indicated that you did not do it, it's not requiring you to do those additional items.
Yeah, that was the same. This is Lori. That was the same question I had in terms of blood pressure was if a patient refuses or you're unable to obtain or you didn't do it at all for whatever reason, how do you document that? Because I was finding that to be a challenge as well.
Okay.
But yeah, and I think the, not doing it because of parent refusal or something like that is a bit of a different scenario than not doing it for another reason. So because it's not for lack of your processes within your office, that kind of thing, it's because of a parent decision. Yeah, we'll check into that. That's a great point to bring up, and I think something, we want to be sure is reflected appropriately. Any other questions?
I had another. Oh, I'm sorry. Go ahead.
Oh, go ahead.
I just had another question. I I had to, because our practice is relatively new, I was having to really search for well visits, and I spoke with Renee about this. I had a preponderance of infants and young children. I didn't have as many 3, 4, and 5-year-olds from which to select, at least not at this point. They're coming in now, and we have more children coming for follow-ups now for well visits moving forward. But one of the issues I was finding, and I wasn't really sure how to document, I just opted for something that seemed to be as close as. But I have a lot of babies who aren't actually gaining weight well, and I know a lot of the issues we're centering on are healthy food choices, helping children not to be overweight or obese. But I actually have the opposite issue with so many children, is that they're actually underweight, even older school-age kids, that they've been neglected, they're malnourished. And so my smart phrase goal, I struggled a little bit with how to say what our my goal was for that child or family, because again, it might be portion size or it might be food choices or something, but it tended to be slightly different in terms of how I was phrasing. I did my best, and I chose what I could that seemed to be most logical, but many times it really wasn't ideal. I don't know that there's any reason to change. I just wanted someone to know
Yeah, that's
that.
a good point to bring up. And you're talking about the topic. So if you set a goal and then the next question was, what was the topic of that goal?
Yes.
Most of those are obesity preventative. So you're right that there isn't necessarily a category that fits when you're trying to have healthy habits but acquire weight.
Right.
So I think as long as you kind of pick, that won't impact your measures. So it's kind of what best fits there. But as long as your clinical note has the key pieces of information that are helpful for you for that next visit, that's the main piece that we really want to help make sure that you have.
Okay.
Yeah,
Right,
and this is Amy. I just don't want anyone getting tripped over fitting it into the perfect category, because obviously if you're attentive to the nutrition concerns and you're addressing the underweight, that's the bottom line of the whole idea of this. It's really supposed to be development of healthy habits, even though underlying there's obesity prevention. So we certainly want you to get the credit that's due for your efforts.
This is Alana Milton from Nationwide, and this kind of speaks to what Amy just mentioned. I had brought this up with Renee the other day. So our goal in, very young children is exclusive breastfeeding for best health. And, last month's pediatrics actually had some, beginning data on that as well versus EBM from a bottle. But one of the challenges I have is the verbiage we use for weight status, and say a 2 or 4 month old exclusively breastfed baby, if we're looking at their BMI or their weight for length, and they're one of those big, chubby babies, there's nothing I'm going to tell them differently. I want them to continue doing that practice. So how would you suggest, I don't want to write obese on the chart of a 4 month old exclusively breastfed baby who's meeting all their other, goals that we have. So how would you address that we manage those babies?
Well, Sam, you know more specifically about the actual categories, but I'm going to mention that in my talk, and basically that you're absolutely right. I mean, we anticipate increased weight gain. The rate of weight gain in an exclusively breastfed infant is usually much higher than formula fed. So, I mean, again, I don't want you to get caught up in the category as far as what is fitting into our QI project. I mean, I would say the goal would just say continuing exclusive breastfeeding. Normally with time, that rate of weight gain may slow down in the second part of their year. So again, it's not, if you're identifying if all the kids are obese and they're all exclusively breastfed, that's okay. Does that answer the question?
Yeah, absolutely. Thanks.
Yeah, and I was just going to add on to that with the data in the KETA system as you're entering. I mean, you can classify them as that, but I don't think that's a diagnosis or anything that needs to be made in the chart. That's just where it fits as you're entering, but it's certainly not anything that needs to be, as Amy mentioned, kind of moving the trajectory of what you would continue with your recommendations.
And I think from a documentation standpoint, if you're interested in putting like reviewed weight, healthy per, assessment or something, just to note to yourself that you looked at the weight but because they're exclusively breastfed, they're on the right trajectory. So I think that could be something to help with that documentation standpoint. Like, you reviewed it, you did the assessment, and they are, where they're supposed to be versus you
putting that label on versus
right.
Weight per length. Yeah. Okay. Great.
That might be an option for you if that's something you're interested in.
Yeah. Great.
Great questions. Is there anything else that folks have noticed as they move through the chart review process? Okay. So with that, I would like to again welcome our medical director for the Parenting at Mealtime and Playtime program, Dr. Amy Sternstein. She's going to talk to us today about really understanding growth charts and how to turn that into goal setting. Amy?
All right. Thank you very much. So I just wanted to start out with and remind everybody that, first of all, effort is the most important piece of the quality improvement project. So I know that, we have our specific aims, but it's okay if your aim is lower than our aim, but if you're showing improvement and you're very cognizant of what you're doing now versus what you could do to improve, that's the bottom line. So I just don't want anyone getting too stressed out about the exact numbers and making sure that everything fits perfectly. However, that being said, both Samantha and Renee are just awesome at answering your questions when it comes to some of the logistical piece. So I just wanted to talk first about just growth charts and remind everybody that we're following trends. And this is a cartoon, of course, measures that we do need to define the growth of the child, and we do need accurate measurements. And here's a coach who's just thrilled because they have found a 7-footer. So that leads me to the next slide, which really is talking about perception. So I just want you to be very aware that parents have a certain perception of the child's growth, weight, height, all of that. But we are the ones that are providing the true reality of the measurements. And then this, of course, is a gal who's on the scale, and she's been eating M&Ms, but she's been reading it upside down. She thought it was Weight Watchers for WW. So this also, again, reminds us. So what are the pieces of the parental perception? We just have to be very, very sensitive to the parents and acknowledge these differences, because there is a difference in perception of weight based on ethnicity, cultural beliefs, the social norms. But as you all know, at the beginning, we're measuring their head circumference, the length, the weight, and then the weight per length, and that's before 2 years of age, and then switching to the BMI chart after age 2. But these growth charts are our best indicators of not only disease risk, but also any kind of successful intervention. So just like you had mentioned that there are some kids that are actually underweight, it does give you, oftentimes it kind of tells you a story. So there's been questions about breastfeeding, breastfed infants. So I want you all to know that from birth to 2, and you probably already know that, but we're measuring weight per length, and there are options. There are 2 growth charts. The CDC was the original growth chart, but in 2010, the CDC recommended using the World Health Organization chart. This was based on an updated data. It was statistical distribution of infants' growth, but predominantly breastfed infants that were exclusively breastfed for the first 4 months, and then they were still breastfeeding by 12 months of age. So in 2010, the CDC had recommended that we switch to the WHO weight per length. I know in Nationwide Children's Hospital, we have lots of different data sets for growth charts in our medical records, and you can define which type of chart you need to use. And actually, our medical records has both the CDC and the World Health Organization, but you have to look and see which, if you do have electronic, which one does your hospital default to. I also wanted to mention that your growth pattern, hello?
Sorry,
your growth.
Quickly, if you need these growth charts, they are in the PMP homepage, so you can access them there.
Thank you. And that the growth pattern will depend on the feeding method. So Alana asked a question about the exclusive breastfed. So breastfed infants do gain rapidly, typically in the first 4 months of life, but then their rate of weight gain does slow down typically between 6 months and 12 months. So if you're using the CBC chart, they may show the opposite pattern, where they're gaining less in the beginning and then more at the end. So I just wanted you to be aware of that. But it's okay to use either one depending on what your office has. But I do want to acknowledge that typically by 12 to 24 months, the weight of the breastfed infant and the formula-fed infant tend to be fairly similar. So we'll keep that in mind as well. Oops, I didn't mean to advance that. So starting with 2 years of age, then we flip over to the BMI chart, and that is only the CBC chart is available. But I wanted to also talk about some expected weight gain. So when you look at children after 2 years of age to puberty, actually when you look at the references, they'll tell you the expected weight gain is 5 pounds per year, which is not very much. Sometimes I educate families that we'd like them to just stay within 10 pounds of weight gain per year. But this is based on an anticipated height growth of 2 to 2.5 inches from 2 years of age to puberty. And then I want you to be aware of disease-specific growth charts. So clearly there was another question also about the premature infant. So there's a different growth chart for them. We do actually, I don't have Turner's listed on this, but of course Down syndrome has its own growth chart. We do have obesity growth charts as well for some of the older kids. But you have to consider that if you have somebody who has a genetic disorder. So why is the BMI so important? So historically, the BMI was really not used diagnostically. And so, there's an unfortunate trend, but it is becoming its own diagnosis. But remember, it's really a screening tool. It's just a proximate adiposity gauge, and it's only valid between 2 and 20 years of age when we're using it with percentiles. But the biggest message, and you guys all may know this already, but I really, really want to focus on this physiologic nadir, which typically appears in the preschool age. So how do we define the weight status now? A lot of practices are putting weight status on their problem list, so however they've defined it. And typically the BMI less than 5 percentile is considered underweight, 5 to 84 is healthy weight, 85 to 95, 94 is overweight, over 95th is obese, and then over 99th percentile is considered extremely obese. The colored growth charts are great. I have tried to get our institution to implement them because it's very helpful when you're talking with parents, and you could say the green zone, the yellow zone. My efforts have not come to fruition. But even if it's black and white, I think the point here we're trying to make that this is an example of a 10-year-old boy, and you can see that if you look at the bottom here, that if a BMI of 13 would be considered underweight, a BMI of 18 is in the green zone, that's considered normal weight, and a BMI of 21 is considered overweight because he's above the 85th percentile, and then as you move up in the red zone, he's considered obese if they're greater than 95th percentile. So really it's just reminding us that it's not just the age, it's the gender, and it's also based on their height. So this is a curve that just shows you why are we using BMI percentiles? Why is that more important than the absolute number? So here's an example of a boy who they both have a BMI of 23. The 10-year-old BMI is considered to be obese, but the 15-year-old BMI of 23 is considered to be in the normal weight category. So this is also an important thing because our body composition clearly changes over time. So this is the point and one of the take-home messages about the expected physiologic nadir or the drop in the BMI. We oftentimes don't see this as commonly as we used to. Most of the preschoolers are less interested in food, much more interested in playing, and we do anticipate that there will be a drop in their body fat percentage. So even that breastfed, robust healthy-looking child, as you know, as soon as they become more physically active and moving, their calorie expenditure increases, and we really expect children to see this physiologic drop. Because unfortunately, in this day of age of obesity, now we're seeing very, unfortunate, where we see a BMI that may have been within normal at 2, but then at the 3-year checkup it's higher, 4-year checkup it's even higher, and each annual year you're seeing an increase in the BMI instead of seeing that anticipated expected drop in BMI, typically about the native. And I teach some of the residents that, and this is just an average thing, but by 4 years of age, which is when we often see that physiologic nadir, they should weigh about 40 pounds and be about 40 inches tall. So it's the rule of 4s, which sometimes is easy to remember. So as we mentioned before, the growth chart can also be very, very helpful when it comes to looking at a disease process. So this is just an example showing you that this is a case of acquired hypothyroidism. So, and this person actually didn't even have that much of a significant weight gain, but oftentimes you see that drop in the height velocity, which is your tip-off for sure. All right, so we are in the prime position for prevention, and so when we think about it, we're so privileged in that we have anywhere from 10 to 12 well visits between birth and 5 years of age. And so when they ask parents, who do you consider to be your expert, what information, even though they have internet information, believe it or not, they actually oftentimes say it's the health professional, it's that primary care provider that still provides the really important information and they listen most to. So we have an amazing opportunity to really look at their growth over time. And that's what the whole premise of the PMP is that it's not just obesity prevention, but it's really also looking at building that healthy foundation. So this is an example of a child who was moving in the wrong direction with an increasing BMI over time. And so ultimately, we feel like if we do some goal setting early on, we can alter that trajectory. So that's really the main point, is we want to catch it before it gets too significant. So you will all know that as you get through the KETA, one of the QI aims is to really use some of the motivational interviewing skills and define some goal setting. Last time we all talked, Samantha went through what is a SMART goal. And so to be a reminder here, S is for specific, M is for being something that's measurable, A is action-oriented, R is realistic, and then T is for something that has some definition of time. So I'm not saying you have to be anal about this, but there are some evidence-based messages that we really feel that have been significant in the foundation of health. And I typically, I'm just going to go back to this slide for a minute, because when I'm looking at defining a goal, what I do when I use my motivational interviewing is I may approach it first with an affirmation, because you're going to get into an area where you may feel that there's some improvement, and they may not see it as an area of improvement, but you know in your heart that if there was a change, that perhaps this would improve. Like even the family that was underweight, maybe adding Pediasure would be an option if the family was willing. So I approach with an affirmation, and I may say something like, I see how attentive you are to your baby, and I acknowledge how much you care. Or your baby looks so healthy and happy. You're doing such an excellent job parenting that child. Because once you kind of increase their confidence level and you acknowledge that they're doing the best they can, I think they're more receptive when you come out with potential recommendation. So, for instance, if you're talking about juice, you may mention, let's see, where I go. Sorry, I didn't mean to hit that. I have a computer that turns dark, and I have to keep tapping it to make sure I don't lose the screen. But like the AAP has revised their juice recommendations because of excess sugar, and you can say that to them and then say, what do you think about that? Or, what are your thoughts about your expected duration of breastfeeding? I mean, it's fair game for you to ask those questions since you can be able to address them. So here are some 10 evidence-based messages that were originally defined as early as 2007, and then the expert committee that did a large publication in 2007 was revised in 2015. But really, there's not that much change in what they consider to be the evidence-based messages. And then, they're pretty obvious, I think, for most of you that you know this, that exclusive breastfeeding and the change in the juice recommendation. I do know there's parents that rely on juice because of constipation, and that's a factor that's oftentimes dominant in their mind. But fruits and vegetables, we're just trying to introduce them as early as possible with variety as possible, even though most toddlers go through food jags, which means there's certain things they just will not eat. But if you keep offering it, it's amazing how their acceptance level can improve. Free play, you all know there was a policy recently through the AAP about how important free play is in their development, limiting screen time, and eating breakfast family meals. There's some good data out there saying that family meals have really made a difference without distractions because it keeps that feeling of bonding and resilience for the kids. So here are some examples of some of the what we consider to be SMART goals. So, and again, I'm not saying you have to use these, but for instance, maybe you may talk about no juice or limiting juice and really just doing a half a cup, which is only 4 ounces a day, which is the requirement. You might say something like, okay, let's see, if you identified there was a lot of sweetened drinks that are available, maybe you'll say, let's cut out some of the drinks for 2 weeks or 1 week and see how it goes. I mean, the idea is you'll get a feeling of the responsiveness of, oh, yeah, that would be easy to do, or no, there's just no way. Like Grandpa buys soda, and he lives with us, and he takes care of the kids, the majority of the time. There's just no way we're going to get the soft drinks out of the house. So you have to be obviously acknowledging where they're coming from, but it's okay to give suggestions. We really worry about, bottle in the bed and propping, and maybe that's something they can do for 7 days, or the other idea is, my computer just went blank, to try just drinking maybe 3 servings of milk with meals, but then water in between, and that may be something they can do until the next checkup, or within, you may see them on a sick visit as well. Tummy time is something we're really trying to encourage because kids tend to be in confined areas. So that might be something. That's something maybe every single day they can make a point to have some tummy time in the infants. Some of the goals that may be appropriate for kids that are older than 12 months of age is really if they're reluctant to have some new food or some vegetables, maybe go ahead and offer that at the beginning of the meal when they're really most hungry. Try that for a few days. Try that for 7 days or a week. Commit yourself. Is it possible for you to turn off the TV or take the phones away or do whatever, tablets, and take them away and just try to have a family meal without distractions? Let's see. Also a lot of times the parents are saying, oh, the kids won't eat what I serve, but they make a separate meal for their toddler. So is it possible for that toddler to eat the same food that the rest of the family eats just for a few days and see how it goes? And then there's a lot of fast food, which you all know. And so once you've identified that, you can get a better sense of whether, that's something that is negotiable or not. I did want to mention that based on this expert committee recommendation, there are some goals that have been set based on weight loss targets. But if you look at the categories for the 2 to 5-year-olds, basically what I tell families is oftentimes we're going to hope to lower the weight velocity, meaning that, as I said earlier, that if the recommendation is to stay under 10 pounds of weight gain per year and they're gaining 15 pounds or more, then that may be an area where you can decrease the gain. Or weight maintenance would also be a potential goal in mind for sure. I mean, it's interesting because really what I told you before is 2.5 inches of height growth per year should only correlate with 5 to 6 pounds per year. So that's less than 1 pound per month, which really can be fairly shocking to families when they hear that. So I want you all to have a lot of optimism about this. We do have an opportunity to decrease the rate of the gain, but I do want to review the expected growth patterns, and you guys may all know this, but I think it's a really good reminder that infants typically double their weight by 4 months. So that is expected, and they'll triple their weight by 12 months. But that growth does depend on their initial weight, obviously, if they were a preemie or their gestational age. And that's why we want you to use the premature growth chart if that's the case. But based on the feeding method, remember that the breastfed infant does gain rapidly within the first 4 months. But by 12 to 24 months of age, we do expect the breastfed and the formula fed to have fairly similar weights. And then with the height growth, they can grow as much as 10 inches in the first year of life, and then oftentimes they reach half of their adult height by 24 to 30 months of age. So sometimes I just, without judging anybody with the families, I just give them the expected stuff, and remember that the growth chart oftentimes can tell a story. I mean, if somebody's sick, they may lose weight. If somebody's had a major change in their life, if there's been somebody that's died in their family, and food has become a source of emotional support, they may gain weight. So I do, when I'm looking at growth charts, oftentimes, if I do see a change in the trajectory, either up or down, I will ask, I'll say that this oftentimes tells us more of a personal story. So can you tell me what was going on during the time when this changed? And oftentimes when you approach it like that, I feel like parents are much more receptive. Any questions?
Does anyone have any questions about the different growth charts, setting goals for families?
I do not.
Do those seem reasonable? I mean, again, you can make them small goals, you can make them larger goals. I would just be really in tune to what you feel the